Good
Preeti,
evening,
can you
everybody.
hear?
Yes,
Yeah, yeah,
I hear.
Okay, okay, great.
Can you hear me?
Okay, we welcome Dr. Rao sir to start the welcome address for all of us.
yeah. Good evening, everybody. I would like to first start by congratulating Dr. Shilpa and Dr. Sharma for an excellent CME yesterday workshop and CME conducted at Bhaktivedanta Hospital, and it was a well attended CME with very uh, informative and uh, practical for the delegates. In continuation with that, we are today's CME is something about things which are not done by most of us. Maybe they are rarely done, but now I think in the current scenario, it is better to know and be aware of what all things are done and how to do it. The topics well chosen by Dr. Farzeen and Dr. Praveen, CSF rhinorrhea and the anesthesia implications, uh, DICE, pediatric foreign body, cardiac lab procedures, and we have our own team of speakers from ISA Boroli, Preeti Dikshit, Vanita Sheth, Gauri Pawar, Kedar Pote. So next 2.5 hours are going to be very informative. And lastly, I would like to remind you all about the upcoming BSACon 2, which is scheduled to be there on the 7th of June. And we have Dr. Meenakshi Sundaram, President-elect National ISA, as a guest of honor to deliver the keynote address at that day. The details will be put up soon. The venue has been finalized, and the details and the uh, payment schedule will be put up soon. So I pass on the mic to Dr. Farzeen to continue introduce the topics and the speakers. Thank you. Dr.
Yeah, so
Farzeen, can you take over? Yeah.
the first speaker is Dr. Preeti Dikshit. Madam is basically freelancer anesthesiologist in Mira Bhayandar area since last 14 years. Madam is also co-founder of Navigene Genetic Sciences 2012. It's been 14 years now, and she's also associated with NGO which is there in Nagpur. The topic for Madam today is CSF rhinorrhea repair and anesthesia implications, her personal experience. Madam, over to you, Dr. Preeti.
Okay. Thank you, Praveen, for the kind introduction. And at the outset, I would like to thank ISA Borivali, all office bearer, Rajesh Rao sir, Shilpa madam, Dr. Krupa Shah, Dr. Farzeen, Dr. Praveen to give me the opportunity. As the theme goes, it's rare, so better be aware. The CSF rhinorrhea surgery are not being done during my residency or during my DNB tenure. But since last 3 to 4 years, this case which I'm going to present is my fifth case. So we do work in a team. So this is a teamwork. I'm coming to my case.
Madam, you're not audible. Preeti, madam, your mic is. Yeah.
Able to hear, na?
Yes,
Am I
madam.
audible?
Yes,
So I
madam.
got a call from neurosurgeon. We have to do a case of CSF rhinorrhea leak repair on 14th of Feb. So patient would get admitted on 13th, and we will be doing a case on 14th 2 p.m. So since it was a 14th, I had to go for dinner. I asked him कि अरे कब तक खत्म होगा? So he said कि ठीक है, though around 6:30 it will be finished. So patient would get admitted on 13th, and I got a call on 14th morning कि madam, The patient is having cough and breathlessness. So come and do the PAC as case is posted. So when I see the patient in ward, she's a very cute lady, 59-year-old female, diagnosed case of CSF rhinorrhea and posted for surgery at 2 p.m. But now she is having cough and breathlessness. So on the examination, she is a obese female, 59-year-old female, 89.5 kg weight. On visibility, there is a short neck, double chin, and there is a continuous dribbling of watery fluid from right nostril, which is more during sitting or standing position and aggravated by cough or any other activity, but less on lying down position. Now she is having breathlessness and cough present. Past history में she is a known case of hypertension. Newly diagnosed diabetic when she was admitted in hospital 1 week back, which was not told by the surgeon prior, but which was seen when PSC was done, and she was hypothyroid on treatment. तो ये केस posted है, पूरा investigated है, but now she is having cough and breathlessness, which on examination there are bilateral creps. Heart rate is 84, conscious coherent, respiratory rate is 24. SpO2 on room air is 92% and creps. So while I got the call, I told RMO to do a fresh X-ray chest, give nebulization and send ABG. So by that time the ABG ka report comes and the patient was given reference to chest physician. Chest physicians put the patient on BiPAP. So when everything was seen around 1 o'clock, the surgery was postponed because chest was not that good. If we do the surgery, patient might land upon ventilator. So all these things were explained to her and told ki today we are postponing. Might be we will do on Monday, which is 17th, but still in 2 to 3 days, the ABGs had not improved. The ABG report was like that. She is having PCO2 of 33, but PO2s were 54. And serum lactate was like that 1.07. So obviously the patient was on BiPAP and patient was postponed for that day. She took 3 to 4 days to cough to settle, the creps to settle, and the ABG to improve. So on 19th, she was taken up for surgery. So after explaining and proper counseling, the need of the emergency surgery since it is CSF leak, continuous CSF rhinorrhea, which can land up into meningitis. So we need to go for emergency surgery. But since the chest condition is like that, patient may require ICU backup or ventilatory standby. So she being so cooperative, understanding lady with her family by her side, she said ki whatever you do, I am okay with it. So patient taken to OT, standard monitors, ECG, NIBP, SpO2 were attached. 22 gauge cannula was in C2 in left hand, but since she being chubby and there were limited IVSs, so 1 day prior only, central line was asked to put in the ICU. So the plan for the CSF leak repair was general anesthesia with lumbar drain placement to drain the CSF continuously at least for 72 hours. So with this discussion, I had asked surgeon कि I can put the lumbar drain prior in sitting position before giving GA. But the surgeon was reluctant to do that, saying कि madam वो needle काफी बड़ा रहता है. I would prefer to put it after GA in lateral position. Since we have done these cases prior, we know कि lumbar drain lateral position में डालना थोड़ा difficult होता है with patient being obese and positioning nahi aata hai. But since it had been discussed and surgeon was confident कि नहीं, we would do it in lateral. So I had gone ahead with GA first. So GA में na routine like pre-medication, induction. So our DNB student of 2 months says कि मैडम anesthesia में तो same ही है ना, pre-medication में 3 ड्रग देने का है, induction में 2 ड्रग देने का है, फिर maintain करने का है. So I would like to tell at this and being discussed by so many speakers कि anesthesia can be compared with all our masalas in kitchen कि मसाला तो सेम ही है but outcome तो सबका different रहता है requirement. So premedication routine like Glycode 0.2, Midas 1, Fentanyl 100, Propofol 120 mg, Scoline 75 mg was given, and patient was intubated very gently using video laryngoscope in first attempt. Throat packing was done. Since it is a ENT kind of surgery, endoscopic surgery, throat packing is must. So while putting throat pack, we have to remember to remove at the end of surgery. When we work in the team, the things do happen. If one person has induced and if that person has to leave for another case and the second person is there, so over में अगर throat pack नहीं दिया गया, तो at the end of the surgery, the person we may miss to remove the throat pack. So it has to be emphasized कि in the case whenever the case the throat pack wherever it is put, it has to be removed at the end of the surgery. So throat pack was put and the maintenance was on oxygen, nitrous, sevoflurane and intermittent atracurium. After this induction, patient was given lateral position by putting proper 2 pillows between the legs and the L3, L4 space was palpated. The lumbar drain was attempted by surgeon, but in 2 to 3 attempts, it was not done. So our team member has to intervene and she has to locate the space properly and put in the lumbar drain. So lumbar drain is a kind of set which is there is a EVD like of set and a epidural needle which is 14 gauge and a catheter which is to be put, and there is a 3-way.
Priti madam, can't hear you again. Priti madam.
So this is the video I'm showing. This is taken from internet. As I could not record the video of the actual procedure of my case. So this we are locating the epidural space in lateral position L2, L3 space. This we are into the epidural space. See nice CSF flow. And now we have to put the drain. So this drain is material is different from epidural catheter. It is a barium impregnated silicone material. So next slide. I'm sorry, thoda sa technical. So this catheter, lumbar drain catheter material is different from epidural material, which is a silicone material and slightly softer. So while putting, we have to put with the guide wire over it. So this, once the CSF flow comes, this lumbar drain catheter we are putting, and it is to be added with the EVD drain box, which is there are 3-way connector to control the flow. So this is the set. So once the lumbar drain was put, the surgeon stands on the right side of the patient so that our console has to be on the left side with monitor on the left side. And while intubating only, we have to take the endotracheal tube on the left side to maintain the ergonomics. The IV line has to be connected with 100 centimeters extension so that we have the access at the foot end and we are not in their field as we share the field with the surgeons. So the surgical time in a CSF leak repair, what do exactly the surgeon does? It is an endoscopic endonasal surgery, which is minimally invasive surgery. which seal the skull base leaf via nose by using grafts. That grafts could be fat, fascia, or mucosal flaps. For our case, we use the fascia lata graft. So, the surgical time for this case was 2.5 hours. At the end of surgery, the ABG was 7.25 pH, PCO2 was 46, 192 by PO2. But there was a sodium bicarbonate level of 20, so base deficit of 7, and lactate was 2.6. And with the prior history knowing she was on BiPAP, we have decided not to extubate her and send her to the ICU for ventilatory mode for overnight ventilation with sedation and paralyzing. So sedation, dexmed sedation was given in the dose of 2 microgram per kg per hour, and atracurane infusion was put overnight. So this with this overnight ventilation, her ABG chest condition slight improved, and she was next day wide awake, and we have extubated her following commands. We have extubated next day morning around 10 a.m. and the lumbar drain which she was put in was draining continuously. She was in ICU for 5 days, and around 900 ml drain was there. With that, her condition improved. There was no leak which was seen after 3 to 4 days, and she was discharged from ICU. So this is regarding the case. When we come into picture for the CSF rhinorrhea, when the case is being diagnosed by physician and being referred to neuro or ENT surgeon. So how to diagnose is the crux. Even though these cases are rare, the Indian incidence have been increasing. We are getting quite a lot with ENT surgery, FES surgery also. If there is a traumatic trauma to the skull base, then also there is a CSF rhinorrhea. Then also we have to go for the CSF leak surgery. So this patient was discharged on day 5 with all happy face, but prior to that, she was admitted on 4th of Feb with the history of fever, high-grade fever with chills for 2 to 3 days, and clear watery nasal discharge which was going on and off since 1 month, severe headache, severe generalized weakness, cough with yellowish expectoration, and nausea on and off since 1 month. In this 1 month, she had been shown to various GP which were not able to diagnose her condition. But when she came to the hospital in which we have operated her, she was seen by the neurophysician and being diagnosed. On the first admission, when she had a fever, she had a heart rate of 110, BP 100 by 77. With temperature of 101. With bilateral bronchi, CVS, soft. All other investigation were okay. Past history, she was having hypertension on tablet amlodipine, diabetes on Gamer-1, hypothyroidism on tablet Altroxin 50 microgram. For initial hospitalization, CBC, CRP, LFT, urine routine microscopy was done, in which WBC count was 19,000, CRP were elevated by 50, X-ray chest showing the left lower zone haziness. My slides are running faster than me. She was then started on the first hospitalization. I'm sorry, I'll wait for 1 minute.
No problem. Take your time. Are you back, Dr. Preeti?
So there was in initial admission when she had fever, the WBC count was 19,000. CRP were elevated around 50, and there was an inflammatory and infective process going on with X-ray chest showing haziness in the lower lobe. Patient was started with IV antibiotics, Monosef 2 gram for 5 days. Nebulization with Foracart was given. And based on clinical condition, the neurologist suspected the CSF leak. So for that, to diagnosis, specific tests were advised. That was CT cystonogram, MRI brain plane, HRCT chest due to as she was having persistent cough, fundoscopy in view of suspecting the high intracranial pressure, MR venograph, and CSF for beta transferrin. So out of these, CT cystosonograph and CSF for beta transferrin are the specific tests to diagnose the CSF rhinorrhea. In CT cystosonograph, we inject a dye in subarachnoid space. So this test is, this CT scan is done for the patient, and to inject the dye, they generally anesthetic is being called. I have not given gone for CT cystosonography at present, so I do not know. But then I have talked to radiologists. They say ki we do call for anesthesiologists to inject the dye, so it is done under all aseptic precaution. In the CT scan room, we inject around 2.5 to 3 ml dye. Here in the report they have said 6 ml of non-ionic contrast was injected in the intrathecal space, and after the dye being injected, patient is given the head low position. So in cath lab, we cannot give, the table cannot be done head low. So during that time, they just keep the leg, they elevate the leg for some time, 3 to 4 minutes, and the dye then traverses up to the head region, and then the serial CT scans are taken, one before the injecting dye and the next after injecting dye. So for this, during CT cystosonography, the defect of approximately 2 mm noted in the right cribriform plate with active leak of contrast in the nasal cavity. So MRI brain and plane contrast was done, suspecting any intracranial hypertension, which shows empty sella turcica with prominent Meckel's cave, which may present early changes of benign intracranial hypertension, and clinical correlation was advised. Prominent venous channels in the scalp of scalp soft tissue over the occipital and upper cervical midline region, communicating with the confluence of sinuses. This was the report for MRI brain with contrast. HRCT lung showed the fibrobronchitic changes in the superior segment of left lower lobe, which is sequelae to healed infection. That's how she presented with recurrent cough and crepitations. Fundoscopy, since there was a report of the fundoscopy showing the possible intracranial hypertension, Dimox tablet by added. Then CSF for beta transferrin, it is a very specific test to diagnose the CSF rhinorrhea. The CSF which is leaking is being tested for CSF transferring beta 2 transferring level. Along the same time, blood is being drawn and tested for the beta 2 transferrin. So CSF beta 2 transferrin is a specific marker for CSF with high concentration present in CSF but virtually absent in blood, nasal or any other secretion. Generally CSF, and at the simultaneously blood is being tested for CSF beta 2 transferrin levels. So its detection is done by electrophoresis, often with sensitivity for concentration of more than 1 microgram ml is used to confirm the leaks resulting from trauma to the surgery. So this is how the beta transferrin level were elevated, and CT stenography showing the leak. She was diagnosed having the CSF rhinorrhea. So neurosurgical then opinion sought on the 7th of Feb, and reference was given, and then the neurosurgeon was involved, and then we got the call, for which we operated, and patient was on ventilator, and she was discharged on day 5 of the surgery. So this is all about the course of the patient when coming to the OT, and prior how she was diagnosed. So now something, I'm sorry, the slides are going faster.
On the IV cell.
CSF rhinorrhea. The slideshow is going faster, that's why there is problem. About the CSF के बारे में. ये तो आया ही नहीं. So what is CSF rhinorrhea? CSF rhinorrhea is a pathological leakage of CSF fluid from the subarachnoid space into the nasal cavity caused by defect in the skull base combined with the breach of dura mater. Under normal condition, the intracranial compartment is a closed hydraulic system. CSF produced primarily by the choroid plexus circulate through the ventricular system and subarachnoid space while being contained by bone and dura. When this barrier is disrupted, CSF follows the pressure gradient from the intracranial cavity to sinonasal tract, presenting clinically as CSF rhinorrhea. There is one more condition, CSF otorrhea, for which I don't have any experience to undergone surgery for such case, but CSF rhinorrhea, we have done 4-5 cases. Etiology of CSF rhinorrhea can be same as any other pathological etiology. It could be traumatic, it could be idiopathic, neoplastic. The most common cause of traumatic includes skull base fractures, especially involving the cribriform plate or sphenoid sinus. It could be iatrogenic following neurosurgical or endoscopic sinus procedure. It could be spontaneous, associated with idiopathic intracranial hypertension, particularly middle-aged patient. It could be neoplastic or congenital. So the difference between the CSF and nasal discharge, CSF leakage of CSF from intracranial cavity due to skull base or dural defect. Nasal discharge is a mucus produced by gland of the nasal mucosa. CSF is clear, watery, very thin fluid. Nasal discharge could be thick mucus. It could be white, yellow, or green in color. Generally, CSF discharge is only unilateral, comes from one nostril. With the same, our patient was having the CSF rhinorrhea only from the right nostril, not from the left. But the nasal discharge is generally bilateral. CSF is salty or metallic taste in the throat, but there is no special taste during the nasal discharge. CSF rhinorrhea may increase when bending forward or straining, which is not with nasal discharge. Persistent clear nasal drip, headache, or possible history of trauma or surgery can be associated with CSF rhinorrhea, but no such history may be there. Only allergy or asthma may cause a runny nose, nasal discharge. There is a high glucose content because CSF contain glucose with CSF rhinorrhea, but with nasal discharge there is low or no glucose present at all. CSF cannot be sniffed back, but nasal discharge can be sniffed back into the nose. Beta transferrin test is very much positive and specific marker for CSF. Beta transferrin test is negative for in nasal discharge. With CSF rhinorrhea, since there is a breach at the skull base, there is a chances of meningitis, which is not there, which could not be there for nasal discharge. So there, so the simple mnemonic to learn about CSF rhinorrhea is clear leak. C for discharge is clear and watery. L for while leaning forward increases the CSF flow. Drift often increases with the patient bending forward. E for elevated glucose. CSF contains glucose, so the fluid has higher sugar content. A for absent infection sign, usually nose seizing, congestion, or typical cold symptoms are there. But our patient had CSF leak with nasal discharge. So it was a combination of both. So to have that initial diagnosis, a proper suspicion was required. That was done by our neurophysician very nicely, because only CSF rhinorrhea is a watery discharge. There is no sneezing congestion, but our patient had both the symptoms. R is for risk of meningitis, because there is a pathway between nose and brain. L for leak from one side. So generally CSF rhinorrhea has a unilateral nasal discharge. E is for endoscopic repair needed for CSF rhinorrhea. And A is for beta-2 transferrin, a very specific laboratory marker, beta-2 transferrin positive for CSF rhinorrhea. And K means cannot be sniffed back easily. This is a small mnemonic for CSF rhinorrhea. Now coming to the CSF physiology, a little bit CSF physiology, CSF production and physiology. As we know, CSF is produced by the produced in the lateral ventricle and circulated from lateral to third ventricle via foramen of Monro. From third to fourth, it is transported by aqueduct, cerebral aqueduct, and from fourth ventricle, it circulates through the subarachnoid space from lateral aperture, which is foramen of Lashka, and median aperture, which is foramen of Magendie. So regarding CSF, regarding the CSF, it is produced predominantly by choroid plexus within the ventricular system. So in healthy adult, the daily production of CSF is around 500 ml per day, which is at the rate of roughly 0.3 to 0.5 ml per minute, or 20 to 25 ml per hour. And this fluid completely replenishes the total circulating volume, making it around 150 ml about 3 to 4 times every day. At any given point, the total quantity present in CSF is about 150 ml, as the fluid is constantly produced and reabsorbed. So CSF is clear and colorless, resembling the distilled water under normal physiological conditions. The specific gravity of CSF is 1.004 to 1.007, reflecting its low protein and cellular content. The normal intracranial pressure of CSF measured during lumbar puncture typically lies between 10 to 18 centimeter of water in adults. So the delicate pressure balance is essential for maintaining the intracranial homeostasis. Through its circulation, CSF acts as a mechanical cushion, a transport medium for nutrients, and pathway for metabolic waste removal. So of late, so this was our case. She was diagnosed as a CSF rhinorrhea and posted for CSF rhinorrhea repair surgery, which was the endoscopic surgery. Diagnosed for having the specific diagnosis, we diagnosis with the CT cystonogram and beta-2 transferrin level. Initially treated with antibiotics before going for surgery, and after surgery she was relieved of her symptom, and she was discharged after 4 days. Of late, this is the case of CSF rhinorrhea, but of late we have been getting calls to measure the lumbar puncture and CSF opening pressure, to do lumbar puncture with measuring the CSF opening pressure. So I want to show one video regarding how we do the lumbar CSF opening pressure. This, if we don't have the manometer during nursing home level, we do a jugaad. This is a sterile IV set. Sterile IV set, which we mark from every 5 centimeter up to 20, and every 1 centimeter after 20 centimeter. This is under all aseptic precaution, we are doing the lumbar puncture.
And frequently level.
So this we are doing with 22 gauge spinal needles. This nice flow with the 22 gauge spinal needle, and now we have to measure the CSF opening pressure.
So we can see the CSF rising up.
So this is when we don't have the manometer available, we can use the IV set with the sterile scale and marking. We can do the marking over the IV set.
Straight ahead.
And in the same way for CSF rhinorrhea, if you have to put a lumbar drain, and if you don't have the lumbar drain kit available, the lumbar drain kit is around 2,750 rupees. So we can put a epidural catheter, but the difference between the epidural catheter and lumbar drain catheter is the lumbar drain catheter is the silicone one, and we have to have that guide wire which is there in the set. But if we are not using it regularly, we may find difficult to put it, or we may not having that good hands on over it. So this is the technique. Then we can use the epidural set and a 3-way connector to drain the tubing and attach to the EVD drain. So for CSF rhinorrhea repair, the anesthetic implications are 2-3. Like the ergonomics has to be maintained. If we put a lumbar drain prior to induction in sitting position, it is always easier to put. In lateral, we may find the difficulty. It's a ENT surgery, so throat pack has to be put and which has to be removed. And the machine and console has to be taken on the left side. Otherwise, it is like a routine, managing a routine case. In the surgical part, they take a graft, which could be fat or fascia. In our case, it was fascia lata. They repair endoscopically. They repair the leak. They put the graft. In our case, they put the Abgel over the leak, and the leak was packed. And the patient had healed that leak over 4 to 5 days. By that time, 5 days, lumbar drain was kept, and which was removed after 5 days. And during the time of discharge, there was no leak, and she was discharged very happily. So this is a case which was done. And in this era, I would like to thank Almighty God, जहाँ पे आपका सिलेंडर कतार में है और आपको वेट करना पड़ेगा. We are able to manage our cases peacefully and nicely, and we can do all the cases when there is a team available. So thank you, team, and thank you, everyone. I thank my son Akshat, who is helping me with the slideshow because I am not able to do it nicely. Thank you. This is the team with which we did the case.
Great, madam. Thank you so much, madam, for an amazing case presentation. So 3-4 questions we have. The first question is, why you did not wait for chest optimization before taking the patient? We could have waited for another 2.
The ABG had been improved, and if we wait longer, the chances of meningitis are more. So ABG has improved from PO2s of 54. We had improved ABG up PO2 up to 84-90. And already patient ka BiPAP support was requirement was gone down from day 3. Still we waited for on day 4, and we took up the case for day 5. So the more we wait, the chances of meningitis are more. So that was it was the risk and benefit ratio we have to plan accordingly.
Okay, madam. Thank you. The next question is the reason for this CSF rhinorrhea was spontaneous, right?
Yes, this was the spontaneous.
Okay. And one question, this opening CSF pressure, the ideal technique to do is in lateral position actually and not setting position. When you see the CSF pressure, when you do in setting position, madam, it gives false positive. It gives a false positive high values. And ideally,
Okay.
the neurophysician will always tell you to do your CSF pressure checking in lateral position only. Sitting
Okay.
position will give you false positive results many times. One. Second is your CVP manometer can be easily used for this CSF pressure.
Okay.
But your Jugaad technique was nice, madam.
Okay, so we will keep it in mind. But this we thought ki we could manage. But this point is a good point. Ki it has to be measured in lateral position. We'll keep in mind. So same thing. I think ki with the same thing, neurosurgeon wanted to put that lumbar drain in lateral position only.
Always,
But
always.
our concern was that in lateral position we wasted almost 1.5 hours to get that lumbar drain in place. So again, it's a time factor and the expertise, the way we are comfortable in.
Madam, this needles are huge needles. Awake patient making them sit and putting these drains in sitting is actually very uncomfortable for the
No,
patient.
but
That's why
then we the same. His concern was same. But when you are giving in lateral position in the GA, and if you are not doing it regularly, then it becomes difficult. So we need to practice more in lateral position for that.
you did this procedure alone, madam, the CSF drain
No,
or the
no, with the
neurosurgeon was,
team, with the team, we were
the
yes.
neurosurgeon was assisting you.
Pardon?
The neurosurgeon was assisting you too, right?
Neurosurgeon and oncosurgeon were team, and there were three anesthesiologists of there from our team.
So, so we had a similar case where this was a post-op CSF leak. The patient was young, operated for schwannoma. On day 8 or 9, he had CSF leak and he had hydrocephalus. So they had to
Okay.
re-explore. But the plan was drain in from CSF to the peritoneum. It was in
Okay.
thecoperitoneal drain. So they
Yeah,
had
yeah.
asked us to put the basically just do a puncture with a wide bore needle and then they put the drain. They do a laparotomy and then they make the drain between the peritoneum and the thecal.
Yes, yes. That also I had done once, but for this I had to read a lot. So that time I have not read. Though for to make this presentation, I had to read a lot. So thank you for the opportunity.
No, no, madam. Excellent presentation. Thank you so much. Farzeen,
I'm
madam,
sorry
one
for the
question.
technical glitches. It was slides were running in faster time.
No, madam. No problem, madam. Farzeen, madam, do we have more questions in the chat box?
Yeah, I think we have one more question that Dr. Preeti, how was this intraoperative course that you described? How was it different from a traumatic CSF leak? So when there's a traumatic CSF leak, sometimes inadvertently they puncture the CSF. So do they follow the same steps like they did for this case?
Yeah, the whatever the reason would be, they have to pack the seal the leak. So to seal the leak, it in traumatic it could be the multi-layer, matlab, fat, graft, then abgel or more thing they can do it. But since traumatic, I have not done, so I'm
But
not.
from the anesthesia point of view, I think stings
But
remain essentially the same.
yeah,
Dr. Farzeen, can I talk?
Yes, ma'am, of course, please.
Yeah, so actually, I just wanted to stress that in traumatic CSF leak, if there is skull-base fracture, means if that is the cause of traumatic CSF leak, then we have to do RSI. Mass ventilation should be almost nil and no nitrous oxide, and then we don't require the lumbar puncture.
yeah,
Means
okay, understood.
means even
Lumbar
if the
puncture
patient
won't
had
be
some
required.
respiratory problem, yeah, we cannot put the patient on NIV. I just wanted to say that. Thanks.
One more thing, Praveen. Praveen rightly said that manometry is done in lateral position normally. And secondly, I would say you can use that CVP manometer. We routinely do with CVP manometer. If not, you can use the IV extension 100 centimeter wala,
Agreed.
which
Yeah.
can be connected easily to the.
Rao sir has something
Yeah,
to say.
yeah. Did you hear me?
Yes, yes, sir.
So you
Yes,
can
sir.
use the IV extension also. But normally we do with CVP manometer, which works similarly and in lateral position always.
Sure.
Thank
sir.
you. So, Farzeen madam, I think we can move on to the next speaker.
We got some good learning today. Dr. Praveen, any more questions
no,
are there
madam.
in the
Well
chat
done.
box?
We can move to the next speaker, madam.
I think we are done, right?
Yeah, madam.
Yeah. So, very good evening to everybody. So our next speaker, I think Dr. Preeti can stop the screen sharing.
Okay.
Our next speaker has a job that most of us are terrified about. I think one of the legally knocking out people every single day and putting them in exactly the zone which all of us are terrified about. So I'm trying to share the screen. Just a second. Yeah. Yeah. Is my screen visible?
Yeah, madam, we can see you.
Okay. My screen is
madam,
visible,
your screen
right?
not-
No? Okay. Just a second. Can you all see?
No, madam. Can't see.
Am I audible?
Yeah, you are. We can see the screen, madam.
Speaker is something that all of us are terrified about. She's going to talk about obstructive sleep apnea and how you can get through the sleep studies. Dr. Vanita Sheth, she's an MD anesthetist. She's a freelance private practitioner in Mumbai since 23 years. Madam has been a partner at the Safe Anesthesia Solutions Group practice and affiliated to many hospitals in the suburbs, so including Namaha and Criticare Asia. And I think in Metro ENT Hospital, her area of interest is lying, which is the OSA and pediatric ENT. Besides that, Madam is interested in obstetrics and high-risk orthopedics. So we are very, very happy to have you, ma'am. And please go ahead and share your screen. We would get a lot of enlightenment because it's a very rare topic, I think first time discussed, at least in this platform. Over to you, ma'am. Vanita, ma'am.
Yeah, thank you, Farzeen, for that introduction. Am I audible?
Yes, madam.
Hello? Yeah.
Yeah,
Yes.
madam, you are audible.
Yeah, you can see my screen also.
Yes, ma'am.
madam.
Good evening, everybody. After listening to an enlightening talk about CSF rhinorrhea, we move on to my talk, that is anesthesia in DIAS, how I do it. Now, this topic is not widely discussed, not many people do it. So, this is what is required in DIAS. So, what exactly is DIAS? Coming to the history of DIAS, it was first described in 1991 by Pringle MB as a method to assess upper airway obstruction, initially performed using benzodiazepines with variable reproducibility and lack of standardization. Early 2000s saw wider adoption with the use of propofol and improved endoscopic recording techniques. And now with development of standardized scoring systems in ENT like the mode classification, and for us drugs like dexmedetomidine has enhanced its clinical utility and acceptance in surgical planning for obstructive sleep apnea. So what exactly is DIAS? The full form of DIAS is drug-induced sleep endoscopy. So what you see in that, what are you supposed to see is the dynamic upper airway evaluation during pharmacologically induced sleep. So that is used in obstructive sleep apnea. It helps us to identify the site of obstruction, the pattern of collapse, and it guides surgical planning. So, what exactly is a sleep study? Something about sleep study before we actually go to DIAS. So, this is generally done in the night. They have all their equipments to be put onto the patient. It's done in the sleep lab, or nowadays it is done at home also. So, this is done to evaluate the baseline parameters during natural sleep. So it includes a detailed report of the breathing patterns of the patient, including the heart rate. In this, the most important for us to see, it is a very big report, almost a 3-page report. For us to see is the AHI, that is the apnea hypopnea index, and the saturation parameters. So the AHI is a number which indicates the apnea hypopnea index. That is the ratio, how many times a patient goes into apnea and hypopnea in the sleep cycle, during his sleep in the night. So that circled one you can see in the screen is 27.9 for this patient. And the saturation parameters, now this average saturation and the lowest saturation. Now the lowest saturation is important. I will tell you later when we are doing DIAS, why is the lowest saturation of the patient in his routine sleep important for us. So why anesthesia matters in this? Because sleep is not exactly anesthesia. They are two different things, right? So here what we need to do is need to replicate the natural sleep physiology. You have to avoid oversedation, which will lead to airway collapse exaggeration, and avoid undersedation, which will be an inadequate study. So what we need to do is the key skill is balance. So what are the anesthetic goals for us? First and foremost, and the most important, is to maintain a spontaneous respiration, achieve snoring and obstruction patterns, avoid airway instrumentation unless it becomes an emergency. Then we definitely need to intervene, and ensure hemodynamic stability and oxygenation of the patient. Patient selection, this is up to the ENT surgeons, but indications here are CPAP intolerance and surgical planning in OSA. Contraindications for severe cardiopulmonary instability, high aspiration risk. So pre-op routine evaluation of the patient, ASA grading, routine airway assessment is all done. So anesthesia setup is what we do routinely for all patients. In this, a difficult intubation cart, suction, working suction, monitoring setup, and ECG, NIBP, SpO2 routine monitors. Apart from that, the BIS monitor plays a very important role in this. That is a bispectral index monitor. The flexible endoscope, which the ENT surgeon will use to do the study, and a working IEB line. All in all safety standards for general anesthesia has to be followed, even though it is just a sleep study. So what is the target? Which stage of sleep are we targeting here? The gold standard for DIAS is to replicate N2, that is light sleep, and N3, that is a slow wave deep sleep. We're not going to go into details of all this. N1 is when the patient will have significant muscle tone, and collapse here is understated. So N2 and N3 are where the most obstructive events occur in real life. So the favorite drug of choice here for us is dexmedetomidine. a very little brief introduction about this drug. All of us are using it. It's a highly selective alpha-2 adrenergic agonist, induces sleep by decreasing activity of the noradrenergic neurons in locus coeruleus. Rapid distribution, half-life of around 6 minutes, terminal half-life of around 2 hours. Advantages where this plays a very important role is minimal respiratory depression, and it mimics natural sleep closest among all the drugs we have. Limitations are slow onset, bradycardia, and hypotension. All this can be taken care of. This is just a small chart to compare the 3 drugs which are widely used for drug-induced sleep endoscopy: propofol, dexmedetomidine, midazolam. So propofol is rapid onset, excellent titration. But the major disadvantage with this drug is the dose-dependent apnea, and it mimics N3 sleep. Dexmedetomidine, slow onset, moderate titration, minimal respiratory depression. That makes it the drug of choice. Closely mimics N2, N3. Midazolam, moderate onset, very low titration. The respiratory depression does occur in higher doses, and it increases N2 and blunts N3. So how do we do DIAS? So the patient, after taking all consent and confirming starvation, the patient is in supine position. We attach all the monitors. So when we are taking IV line, the sister puts 4% xylocaine drops into the nose. Now this is done because so that the patient can tolerate the endoscope which will go into the nose. Otherwise, the patient is going to wake up because he is just in a sleep, not anesthetized. Okay. So injection glycopyrrolate is the first drug we give, 0.2 milligram IV. This serves 2 purposes. One, clear vision for the surgeon so that he can see properly and record properly. And for us also, because there is lesser secretion, the patient is, there are less chances that the patient is going to cough. Otherwise, with all these secretions and all, the patient start coughing intermittently. Now we start our sedation with 1 milligram midazolam and dexmedetomidine. We take 50 microgram of dexmedetomidine in a 20 ml syringe. That makes it 5 microgram per cc. And we use incremental doses of dexmedetomidine to achieve our end stage that I'll come to shortly. Up to a maximum of 50 microgram of dexmedetomidine. This is given very slowly over 20-25 minutes, 15 to 20 minutes, depending on the response of the patient. Now, propofol is a reserved drug. It is in reserve for us. We use it for very less patients in a very small dose, patients whose target is not achieved with dexmedetomidine and midazolam. One more thing important here is the OT environment should be quiet and dark for the patient to sleep. Now here you have, what do you have to observe? You have to wait for snoring and the obstruction pattern and adjust the depth accordingly. So what are the depth of sedation? What exactly are we waiting for? Snoring, obstructive events, and BIS to be monitored between 60 to 80. We target a BIS around 70. Oversedation can lead to apnea, desaturation, and poor respiratory efforts. Undersedation will lead to a patient movement and no snoring will be there. So here is a small video of the DIAS being performed. The surgeon is standing on the right side and that's a flexible nasal endoscopy getting done. So the screen is right there in front of him. So he's in the nose now. That's a big inferior turbinate you can see. So that's in the nasopharynx. And that's our monitor, the saturation around 96 and the BIS around 77, 78. So now this saturation, what I was talking about in the sleep study. So we do not put oxygen for these patients and we let the oxygen saturation go down and observe how much does it go down during his sleep. So the cutoff mark for us is the sleep study oxygen saturation. We need not supplement the patient till then because he is used to that type of saturation. Okay. And the next thing is, this is not a 1 minute job. The ENT surgeon is going to stay there in the nasopharynx with his scope for around 5 to 7 minutes. The patient is going to go into cycles of apnea, hypopnea, and waking up. Waking up in the sense the respiration will come back to normal. This is what happens throughout his sleep. Now you can see in the monitor that the BIS is now 73, 74. The saturation is slowly dropping. Now these cycles keep on happening for the patient and all the time. Okay, so you can see his saturation here is 88. For him in the sleep study, the lowest saturation was 82. So we are absolutely okay with this. Of course, we have everything ready to intervene if there is any emergency. So what is observed in this? The Vogt classification, that is the airway map. So what is V is velum, oropharynx, tongue base, and epiglottis. So in the picture, you can see velum is the area behind the palate. The oropharynx, we all know, tongue and epiglottis. Now, how does this help us as well? So if there is a collapse at the velum, this patient is definitely going to require an airway as soon as you give him any induction agent. A lateral wall collapse, this patient's collapse is pressure dependent. He will require CPAP or PEEP. AP collapse tongue base, this patient will also require an airway, and post-operative, whenever, if you at all you operate on this patient, he will benefit with a lateral position. With an epiglottic collapse, it is better to use a video laryngoscope. And you have to document all these findings. Post-operative, the patient is kept in the recovery room with monitors and oxygen for 2 hours. Complications and management. Desaturation is the foremost complication. So if that occurs, you stop your procedure, jaw thrust, oxygen. Apnea, you reduce your sedation, assist ventilation. Hypertension managed with IV fluids and vasopressors. And bradycardia managed with glycopyrrolate or atropine. So that's all for this. That'll be, thank you very much.
Thank you very much, ma'am. Very lucid and crisp presentation. And as you said, something which really we had very little knowledge about. Ma'am, I don't think in the chat box there are many questions because everything was very clear. But I would personally like to ask, am I audible, ma'am, to you? I would like to ask if the fasting guidelines are the same as our general anesthesia.
Yes, yes. Fasting guidelines are absolutely the same.
Okay, ma'am. And how long does the procedure usually last, ma'am?
Procedure takes around 5 to 7 minutes, but because we use predominantly dexmedetomidine as our drug of choice, so that takes around 15 to 20 minutes to act. And the procedure per se, the endoscopy would last anywhere around 5 to 10 minutes. So what happens is there are a lot of glitches. Sometimes the patient moves his legs. So you have to wait for that. Most of these patients have something known as restless leg syndrome. Okay. So if the patient moves a little, if it's not hampering your endoscopy, you do go ahead with your endoscopy. That's not an issue. Very rarely they might need intervention at the time in the, like, you need to increase the sedation, maybe a little propofol to, if it's disturbing your endoscopy. Otherwise that's not required. So the entire procedure for us to get started, it takes around 20 minutes depending on the AHI again, for that matter. When I told you in the sleep study, the AHI, so patients who have high AHI, they generally have lower requirement of your anesthesia, sleep medicines, sedation. The patients who have lower AHI have higher requirement of all these medicines. Otherwise, the procedure per se takes around 15 to 20 minutes.
Ma'am, which is your second line of drug besides dexmedetomidine in patients who would have troublesome bradycardia or who are on pre-existing beta blockers? Which is your second drug of choice besides
So
dexmed?
we give midazolam along with that, and
Okay.
again midazolam in very limited doses. In so many years, I've been doing it probably for more than 10-12 years. So probably the highest ever midazolam I have given is 2 milligram. And because again in higher doses it will hamper the respiration and it will not be a correct study,
Yeah.
right? So all
Right.
it's it's a cocktail of which suits patient dependent, whatever suits the patient, and then low doses of propofol if nothing works. So we have had patients who have had, like, bradycardia, like how you said, patients on beta blocker and all. So but
Yeah.
somehow I have seen one glycopyrrolate and then dexmedetomidine given very slowly doesn't really cause so much of bradycardia, so as
Yeah.
for me to stop giving dexmedetomidine.
Agree, ma'am. I think Neelam ma'am was asking when is propofol used in, but you have mentioned that in almost all the cases, very small amounts of propofol you all are using.
No, so propofol also, as I said, like midazolam, it is required in very less patient, very few patients. So propofol, if you have exceeded dexmedetomidine, like we had done a study of few cases of DIAS. We had done a few cases. So the average dexmedetomidine which was required was somehow 37.5 microgram. Somehow it comes
Okay.
to that. Okay.
Right.
And midazolam 1.5 to 2 milligram. Now beyond this, if the patient needs something to get the BIS down
Okay.
or to get the snoring, and they don't reach that stage, which is the end point, the main important end point is the snoring and the obstruction pattern. See, all these
Right.
patients, sometimes they have different complaints. Some patients have complaints only of snoring. That is their main problem. So in that case, our endpoint is snoring. So some patients,
Right.
they come for obstructive sleep apnea, waking up and daytime sleepiness. So in that case, our endpoint will be the sleep apnea, the obstruction. Okay. So all
Yeah.
this and get
Depending
the
on the
BIS
patient.
range around. Yeah, depending on the patient. It's all depending on the patient, their complaints, the requirement of the surgeon, what he exactly wants to see, and the BIS monitors around 70 is our target. Some patients, especially very thin patient, low AHI, they just wouldn't, their BIS just wouldn't come down. But if we have reached to that stage of snoring and obstruction, we then don't really change the BIS. What happens is BIS has a lot of artifacts, right? So when the patient is snoring very deeply, his entire face is moving. So if you see the BIS
Yeah.
parameters, so they may not correlate, but once we have
Yeah.
reached that end point of obstruction and snoring, we take it as an endpoint.
So
Okay.
there is a question, madam. Role of remifentanil. Have you ever used remifentanil for DIAS?
Remy,
Still not.
Ravi, you have to get it for me, no? For me to use. It's not actually available. Actually, there are newer studies. When I started doing DIAS, I think a few years ago, dexmedetomidine was not very much freely available, and it was probably available, but we were not used to, everywhere bradycardia. So we were not used to giving dexmedetomidine. So we had also started using little Fent, little midas, and we tried all that here. Even if you see wildlife studies, everybody is using infusion pump, the target controlled infusion of propofol, TCI
Okay.
pumps, but we don't have access to that. And there are newer studies where they are using remimazolam. अभी वो तो शायद देखा ही नहीं अपने, but remimazolam is like remifentanil. I am not very sure about remifentanil. All these opioids are again going to be little bit of respiratory depressant and all that. So I'm not very sure about use of remifentanil or any other opioid for that matter. The one which works closest to what stage of sleep we are aiming at looks like dexmedetomidine or maybe lower doses of propofol. So you really don't want to, go into the respiratory depressant part of the drug.
We
I
are
can
getting a lot of excellent comments in the chat box, all congratulating you. One question is going as how much desaturation could you possibly allow with a
So,
normal
as I
patient?
showed in the sleep study, so the sleep study is almost done for all the patients before they do a DIAS. So that is the lowest saturation is there in that. So that is what the patient is going through every night. So he is definitely able to tolerate that. And what
Tolerate
happens
that.
is if that, yeah, so it is not like one saturation per se. The patient is going into cycles of apnea, hypopnea, like that. Okay.
Right.
So, not really. And one more thing is recently we had a patient who was, not a great BMI, 33 BMI, female patient, but she was a little, her chest was clear, but baseline saturation was 92. Chest was clear, X-ray was clear, everything. She was an asthmatic, but not taking pump only SOS. So this patient in her sleep study, her lower saturation was 40. Okay, so that patient actually goes to a saturation of 40 in the night.
That low.
So, that low. So, but we spoke to the surgeon. We said this patient is not looking very good. Means for 92 baseline saturation, her weight was 79 or 80 kilos. So, a 80 kilo patient is not that obese to have a saturation low. Chest is clear, X-ray is okay. So we said still we will see what the DIAS is there, because she was very much symptomatic. She couldn't sleep in the night. She had daytime sleepiness and all. So he said, let's do a DIAS and see what is an issue. So just 5 microgram of dexmedetomidine and 0.5 midazolam, her saturation went to 40. So we just refused to go ahead. And she actually required almost 2 hours to come out of this 5 dex and 0.5 midas, which is really. So we told him to get her thoroughly check up. Probably she was ILD and she had a convulsion 15 days ago, probably because of that hypoxia. So we just oxygenated her, got her out, and we said this she definitely needs to be worked up because she's not plain OSA.
Right.
Anything else? Any other question?
Madam, yeah,
Ma'am,
madam,
if
one last
propofol-
question.
Huh.
I'm sorry.
Yeah, go
One
ahead,
last
Dr.
question.
Karan.
Yeah. So, do you do, madam, all these patients in the nursing home without ICU backup, or there are specific indications, specific patients where you ask your surgeon to do the surgeries in the ICU backup? And
So
does
surgery
your
wise,
DIAS,
so DIAS can be done. I mean, all that patient which I just said about that situation who had low SATs and all, we did not go ahead. But otherwise, all other patients are absolutely okay to do DIAS in a nursing home setup because we take all precautions.
not
We do not. Huh.
I'm talking about the surgeries, madam. Later, when you post them for
No.
UPPP or
Surgery. So
lung-based surgery.
definitely, if we feel that this patient has got a large tongue base, epiglottic collapse, lot of other issues, cardiac issues, and all, we definitely do not do such cases in a nursing home setup. The patients are told to be shifted to a hospital for this.
Yeah, thanks,
Ma'am,
madam.
as you had said that there's no access to TCI pump, so if at all you all are using propofol, one of our members would like to ask
Yeah.
if how do you all use it, in small boluses or in a
Small
syringe pump?
boluses, probably the maximum propofol I have used in all these years is 30 milligram of propofol, not more than that. Not more than that. I just give 10, 20, 30. That does the job. None of the patients have required more than that.
Madam, your surgeons must be really quick. I have used 100 mg propofol for a DIAS study also, where the surgeon took around 1 hour 15 minutes for the DIAS study. So you're lucky, madam.
Yeah, maybe yes.
Ma'am,
Thank
any
you so
specific
much.
procedure consent is there for this DIAS? Anything in the
No,
consent
they have
different?
the place where I do this regularly. They have a separate consent for OSA surgeries per se, but not specifically for DIAS. There's no specific consent for DIAS.
But you all have your regular consent forms for the general anesthesia.
Yes.
Filled up.
Yes. Everything is written. Yes. Everything. As I said, all monitorings, all precautions, everything is like our general anesthesia. There are no shortcuts for that, though we do not go beyond a certain limit. But there's no shortcuts for that. Even for standby, I have instructions. Full, I need laryngoscope, this, that, everything, ECG for all patients. So there's no shortcut for that.
Ma'am, thank you so much for this very enlightening talk, and we are very happy to have you, ma'am. Over to you,
Thank you
Dr.
so
Praveen.
much. Thank you.
So our next speaker is Dr. Gauri Pawar, madam. The topic for her is challenges in pediatric foreign body removal. Dr. Gauri madam has done a fellowship from Bardia Hospital, a pediatric fellowship from Bardia Hospital. She is presently freelancing private consultant, and madam is also ex-consultant at BJ Bardia Hospital and associate consultant at PG Hinduja Hospital. Yeah, over to you, madam. Gauri madam.
Yes, Praveen. Can you hear me?
Yeah, madam. Yeah,
Okay.
very clear and crisp.
Okay. Hello, everyone, and thank you. I say thank you, Farzan, for giving me this opportunity. We all know that pediatric anesthesia itself is a very challenging branch, and it's more so when we are sharing a compromised pediatric airway with a surgeon. And if you're doing this case as a private practitioner in private practice alone, then it's like a cherry on the icing. So today we are going to discuss about anesthesia management in a pediatric patient posted for foreign body retrieval. Starting with the airway foreign body, not all airway foreign bodies are emergency, but those which are associated with moderate to severe respiratory distress, foreign bodies like seeds and jellies, which swell in the airway and cause complete airway obstruction within no time, sharp foreign bodies which can cause trauma to the airways, button batteries because of the alkali leakage can cause mucosal damage, perforations within 1 to 2 hours of ingestion or inhalation. They are taken on the urgent basis. Now, since we are dealing with a pediatric population with compromised airway, with respiratory distress, most of the times they are full stomach with increased risk of aspiration of the gastric contents. Handling of the pediatric airway can cause airway trauma, edema, stridor after instrumentation. They might need monitoring in the ICU. Many patients, they need oxygen support, very rarely ventilatory support. So preferably these cases are taken in hospitals which are equipped with ICU backup. Now, if such case comes late night, then it's like a big nightmare for us. So to ease our work, our anxiety, before you reach the hospital, always call OT attendant prior. Ask him to arrange extra staff for your help. Ask him to keep age and weight appropriate equipments ready. And do not hesitate to call fellow anesthesiologist for your help. Many of these foreign bodies happen at the time of eating. So most of the children, they are full stomach when they come in the OT. But to delay or postpone the case because the child is full stomach, and when the child is in distress is not possible, because the morbidity and mortality associated with aspiration of the gastric contents is far less than the morbidity and the mortality associated with hypoxia because of the airway foreign bodies. So we can always optimize the child to reduce the chances of aspiration. A quick gastric ultrasound on table before induction will help us in estimating the risk of aspiration by quantifying the contents of gastric contents. We can always aspirate the gastric contents with the help of RT, but that may not always completely eliminate the risk of aspiration. The combination of ondansetron, dexamethasone works better in reducing nausea and vomiting. Also, a good adequate depth of anesthesia, anxiolysis will prevent retching and coughing induced regurgitation and aspiration. Metoclopramide can also be used as a prokinetic in slightly older kids above 5 years of age in a doses not more than 0.15 mg per kg, given very slowly to keeping in mind the extrapyramidal side effects. To obtain consent for these cases from parents is equally a big task. We have to always explain them everything like morbidity associated with the airway foreign body, urgency, like need to remove it urgently in spite of patient being full stomach. What are the consequences if the patient aspirates the stomach contents? What precautions you are taking to avoid it, prevent, reduce the chances of aspiration? Need for airway instrumentations, trauma, edema, stridor associated with it. We have to explain them the ICU monitoring which may be required after the procedure, need for oxygen support, and very rarely ventilatory support. So everything we need to explain them before obtaining the consent. Now, child with airway foreign body who's in distress, coughing, drooling is very uncooperative to put an IV line. So in such cases, once the first attempt fails, do not go for the multiple attempts. We can always take patient under sevoflurane induction or IM ketamine. Both will give adequate anesthesia depth and at the same time preserve airway reflexes. Avoid any medications like midazolam, which can cause respiratory depression as a pre-medication before securing an IV line. Also, a child who's in distress, coughing, drooling may not accept oral and nasal pre-medication. So sevoflurane and IM works better than the oral and nasal pre-medication. Whenever we have time, we can always optimize these cases by giving inhaled steroids and bronchodilators. IV steroids and IV antibiotics can also be given, especially in chronic and foreign bodies where there is infection. In emergency, do not wait for blood investigations to come. We can directly take the patient in OT with essential radiographic monitoring, imaging. All the standard monitors are used, though EtCO2 may not be reliable in bronchoscopy. All age-appropriate airway trolleys, emergency cart with drugs is kept ready. And ask the surgeon to keep cricothyroidotomy and tracheostomy set ready from their side. The aim of anesthesia for bronchoscopy is keep the patient on spontaneous breathing because that will prevent sudden loss of airway. A good depth of anesthesia, good anxiolysis will suppress the airway reflexes and related complications. Maintain adequate oxygenation and ventilation in spite of the mechanical airway obstruction. And choose your drugs and dosages wisely so that there is a quick recovery of airway reflexes and consciousness. Now, in case of glottic, subglottic, tracheal, or bronchial foreign bodies, a pediatric ventilating rigid bronchoscope is the gold standard, as it will secure airway, allow ventilation, and it can be used as a diagnostic as well as the therapeutic purpose for removal of the foreign body. But at the same time, it can be traumatic. A bigger telescope can have resistance to spontaneous ventilation and escape of gases because we need higher flows can cause OT pollution. So this is the surgeon end of the rigid bronchoscope with the ventilating port to which you attach the ventilating circuit. This is the suction port. Through this your telescope goes and here we attach the light source. Sometimes for the upper airway foreign body removal, surgeon might use this Parsons laryngoscope. Now this has got a port to which you can attach your oxygen tubing for continuous oxygenation. Coming to the induction of anesthesia, inhalational versus the total intravenous anesthesia. Now, which one to choose? Inhalational will always give control over induction. There is like we can prevent the sudden loss of airway with the graded sevoflurane induction. Airway is always controlled, but it can cause OT pollution. It is difficult to maintain the depth of anesthesia. The airway reflexes most of the times are not completely abolished with only inhalational induction. And we can have then complications like laryngospasms, bronchospasms, if the depth of anesthesia is not maintained properly. While total intravenous anesthesia will give us adequate depth of anesthesia, less airway complications because the airway reflexes are suppressed better. But there's always risk of apnea, patient going into apnea, hypotension because of the larger doses. So since there's like no technique, no drug is better over another, we can always try combination of medications to achieve our depth of anesthesia and suppress our airway reflexes. So always start with good anxiolysis like IV midazolam. Start with good pre-medications like glycopyrrolate, dexamethasone. A good anxiolysis will itself prevent retching, coughing, bucking induced complications. We can always start with sevoflurane inhalational induction and combine it with propofol top-ups. The propofol can combine with other medications like ketamine or ketamine with dexmedetomidine. We can always add opioid for analgesia like IV fentanyl in slow incremental doses, like starting with 0.25 to 0.5 micrograms per kg diluted in a syringe, will give slowly, monitoring the respiration. When injected fast, it can cause chest rigidity. It can cause sudden apnea. So it is injected very slowly in increments. A good local application to vocal cords, trachea, that is 1% of lignocaine, not more than 4 mg per kg, will allow smooth passage of rigid bronchoscope and the smooth removal of the foreign body. Now, there are many articles, case reports, and studies where propofol remifentanil combination with or without neuromuscular blocking agents is safely used in pediatric patients for tracheobronchial foreign body removal. Now, this can be used if you have TCI pumps available with you. The flexible bronchoscope has advantage of over rigid bronchoscope is that it is less traumatic. It can be used for distal foreign body removal, and you can spray LA as you go. The modes of securing airway with flexible bronchoscopy always depends upon, you can always discuss with surgeon the site and the size of the foreign body, how impacted it is, the duration the surgeon might take for its removal. So depending upon that, you can start with nasal oxygen. You can give high flow nasal oxygenation. You can use intermittent mask ventilation. LMA can be introduced like AMBU, iGel, through which you can pass your fiber optic bronchoscope. And if the surgeon is going to take more time, you can always intubate the patient, and through which the flexible bronchoscope can be passed. And then you can intermittently ventilate the patient in between whenever needed. These endoscopic masks are available in sizes like infant, child, and adult, which can be used along with fiber optic bronchoscope for simultaneous ventilation. Now, Thrive is a technique that is transnasal humidified rapid insufflation ventilatory exchange, is safely used in pediatric removal of pediatric bronchial foreign bodies. There are many studies where it is used for apneic ventilation in pediatric patients. The advantages of Thrive over high frequency nasal oxygenation is that we can give 100% FiO2 with flow rates of 70 liters of oxygen and with moisture, like humidity of 44 milligrams of water per liter. So we can give high flows of heated humidified oxygen to the patient. The advantages is that it allows safe apneic period of about 30 to 30 minutes without causing dangerous desaturations and with permissible increased levels of PaCO2. It gives PEEP of 7 centimeters of water to prevent atelectasis, clears pharyngeal dead space, and the most important thing is that it minimizes interruptions to the surgeon. The only thing is that the machine this Thrive equipment should be available, and it is done with the ABG monitoring, simultaneous ABG monitoring. Now, to give neuromuscular blocking agents is totally, most of the times the call is taken by surgeon. The advantages of giving neuromuscular blocking agent is that it gives complete patient immobility, prevents airway reflexes and related complication, provides better oxygenation and ventilation, and reduces the anesthesia agent requirement. But the theoretical disadvantage is the distal movement of the foreign body when we are giving positive pressure ventilation. So whenever asked for, we can give scoline, rocuronium, atracurium, like depending upon the duration of the procedure, the drug available, and always confirming once it is given only after confirming with the surgeon, once the airway is secured with the rigid bronchoscope and ventilation is confirmed. The complications associated with bronchoscopy are coughing, desaturations, laryngospasms, bronchospasms.
सुनो, ये भी करना है और ये अलग है उसका,
which are very well can be prevented by maintaining adequate depth of anesthesia, good local application to vocal cords and trachea. And even if it happens, we can always treat it with giving positive pressure and neuromuscular blocking agents. The best way is to prevent it. Airway edema can happen because of trauma to the airway. Sometimes a complete airway obstruction can happen when the foreign body is very big at the time of removal, when it gets stuck in the trachea. So that time you can always ask the surgeon to push it distally, or if possible, we can break it. The surgeon can break it into pieces and remove it, but then it also has a chances of going some pieces distally. Once the foreign body is out, we can always secure the airway with ETT till complete emergence, especially when the child is not fasting. Shift to ICU, always accompany the patient. Shift to the ICU when the patient is completely awake and maintaining airway. Racemic adrenaline can be added to treat airway edema. And sometimes the ventilation can be continued. Like a patient who comes ventilated is sent ventilated. A patient with persistent respiratory distress, severe trauma to the airway, or severe edema, persistent stridor, such patients are sent ventilated in the ICU. Now, jet ventilation is not commonly used in pediatric patients because of the risk of barotrauma, but we can always keep it ready and reserve for conditions like cannot intubate, cannot ventilate, or conditions like needle cricotothyroidotomy. Myself, I have never used jet ventilation in pediatric patients, even for foreign body retrieval. Coming to the esophageal foreign bodies, most of them are asymptomatic. Most of them go unnoticed, pass on their own. But the bigger ones, impacted ones, can give dysphagia, vomiting, drooling, feeding difficulties, neck and chest discomfort. A bigger foreign bodies can cause pressure on the trachea and cause respiratory distress. Also, foreign bodies with like magnets, sharp objects, button batteries, which can cause esophageal perforation, esophagitis, mediastinitis. Sometimes in severe cases, we have seen tracheoesophageal fistulas with button batteries. So such cases, they are taken on the priority urgent basis. The most common sites where the esophageal foreign body is impacted are cricopharynx, proximal third of the esophagus. Well, most of them, they pass into the stomach and beyond stomach level. The cricopharyngeal or upper esophageal foreign bodies can be safely removed with direct laryngoscopy under sedation with Magel's forceps. Sir Kaufman and team, they have used optimized Miller size 3 video laryngoscopy blade, and they have removed upper esophageal foreign bodies in all the patients who have come with the cricopharyngeal or upper esophageal foreign bodies. Now, this is the optimized Miller blade which they have used. This is a classic Miller blade. The optimized blade, the length is they have kept same, but the profile is made from 1/3. Profile is made 1/3 from 2/3, so that the Magel's forceps, removal with the Magel's forceps becomes easier. More distal ones are removed with rigid esophagoscope, flexible endoscope. Now, there's always a dilemma whether to intubate or not to intubate the child during endoscopic removal, because some procedures are so short, like surgeon will tell you that madam bas 2 minute ka kaam hai, nikal jayega. So you're always in a dilemma ki intubate karna hai ya nahi karna hai. So general anesthesia is always necessary for endoscopic foreign body removal from upper esophagus. However, there are no clear recommendations on endotracheal intubations for endoscopic removal of the foreign body. But we always intubate when the patients come full stomach, when the objects are sharp objects with the risk of trauma to the esophagus or airway, small objects which might slip into the trachea while removal, button batteries because of the trickling of the alkali material, and whenever there is airway compromise, always intubate such patients. Now, since we are dealing with patients who are full stomach, we should know that how rapid sequence induction is different in pediatric patient as compared to adults. Now, in pediatric patients, we all know that they are very uncooperative. They don't accept mask before induction. And so to achieve that end tidal oxygen value above 90 is very difficult. Cricoid pressure. Cricoid cartilage is high up in pediatric patients. It's soft. A pressure more than desired can cause shift of esophagus laterally. Also, it can give pressure on the trachea, airways. So the cricoid pressure is not practiced in pediatric patient. Also, a small period of no positive pressure ventilation can cause severe desaturation, especially in infants, small children, and especially when they have got respiratory distress. So in pediatric patients, we follow controlled rapid sequence induction, where we put RT, aspirate the contents, keep RT open, give 20-degree head highs in children above 1 year. Then children are induced with induction agents and neuromuscular blocking agents. A gentle positive pressure is given. Uh, I give it with a JR circuit because the bag is in my hand and it gives more control over the ventilation. It's like you are giving a high respiratory rate, low tidal volume, like a high frequency ventilation, oscillatory ventilation. If you're using a ventilatory circuit, always set a bag pressure APL valve to less than 12. Intubate with cuffed endotracheal tube and confirm with EtCO2. Then the miscellaneous foreign bodies like nasal or ear foreign bodies, they're not an emergency. You can always wait till the fasting is completed. Many of the times a mild sedation or parental presence also works in such cases. So with our awareness, knowledge, good communication with surgeon, proper planning of anesthesia, managing and tackling emergencies, we can always make these rare cases safer and smoother for ourselves as well as our little patients. Thank you. Thank you.
Thank you, Dr. Gauri. That was an excellent presentation.
Thank
With
you,
a
Fazil.
lot of pictures and a good coverage of the topic. Dr. Praveen would like to put up the questions.
There are 2-3 questions, madam. One is racemic adrenaline available in the market for nebulization?
Yes, it is 2.25% racemic adrenaline. We use it like 0.5 ml diluted in 3 ml of NS, or you can always use a regular adrenaline also, like it is 0.5 ml taken and diluted in 5 ml, but racemic works better in the regular adrenaline because the regular adrenaline will give severe tachycardia in pediatric patients especially. So 2.25% racemic adrenaline is available.
It is available. Thank you for that, madam. And there is a question. There's a basic query. Passing an RT in a child is quite okay. So how do you pass RT in a awake child? It looks very traumatic, and the parents are there in front of you. So
first of all, we don't do these procedures in front of parents because they're so panicky. They won't allow to put RT when the patient is thrashing and crying. So we always take them in the isolated room and put. And most of the times they are like crying. So we have to hold them, hold the neck, and somehow we have to pass it. But many of the times it goes. We have to just hold it and put it, Praveen.
This controlled rapid sequence intubation is new for us actually. We had heard about this modified rapid sequence where we actually check the mask
same
ventilation.
as the modified. Controlled is same as modified.
The modified we do not put RT, na? We just ventilate once or twice and then we intubate.
Yeah, we see in the only thing different in the control is the RT. You aspirate, keep it open, but with the RT sometimes the mask ventilation becomes difficult. There's a leakage from the side of the RT, so you have to have the proper fitting of mask around the RT.
Okay,
I'll share the new article guidelines about the controlled RSI with you.
And about this Thrive, madam, have you ever personally
No,
used
I
this
have never
Thrive?
used it. Thrive, I have never used.
We
Many of
have
the
used
places
it.
it's not available. It's
So
what is available is the high frequency nasal oxygenation, and
so
that is
Thrive.
used for spontaneously breathing child. And Thrive is totally different than HFNO. In a Thrive, you're giving a very high flow, like 70 liters. It is more humidified and it gives PEEP. With HFNO, you cannot give PEEP.
So Thrive is available, madam. It is in fact
Yes, in
on
a
rented. It is available on rent also. We have used for 4 to 5 cases of anticipated difficult airway.
okay.
It is an
In your
amazing device, madam. You
yeah,
can,
yeah.
yeah, yeah. So basically, 100 liters per oxygen, the patient is tolerating it very well. Those nasal cannulas, they are very soft, and
Soft,
the
yes.
patient, yeah, patient tolerates it very well. And one thing about this endoscopic mask, you use it regularly, madam?
No, no, no. I
Endoscopic
have not
mask.
used it. I always use my JR circuit and the round mask,
Yes.
and I intermittently ventilate. But these masks are available in the market.
So we had used those masks during COVID. Our gastroenterologist had used
Yes,
during
yes.
COVID, and then eventually we had stopped. After the COVID, we did not use it again. But those were amazing masks.
See, we are so used to with our round mask and JR circuit. We are so
Yes,
comfortable with that.
Few questions are coming up in my mind, Dr. Gauri.
Yeah.
One is regarding communication with the surgeon. I always face this issue as to what cue in a verbal communication do you put across to the surgeon to tell him, okay, pause, allow.
Faizan, can you repeat your question?
Because in a child, you're invariably on your toes. So how do you do you have a particular set of words that you use that he knows that
See,
it's
the
time to
thing
get
is
the
that
bronchoscope out?
no, no. See, in a pediatric patient, the surgeons are more worried than like anesthesiologist. So they will always tell you that saturation 80 tak jayega, tab just tell me to stop. They will tell you, 80,
Okay.
85 tak jayega, ask me to stop. And you are standing at the head end. I don't stand by the side of the patient. I always stand at the head end. And I'm ready with my mask, I'm ready with my circuit, I'm ready with my airway trolley, everything. So whenever the saturation goes below 80, I just ask the surgeon ki bhaiya stop karna. And they also, most of the times we are working with the pediatric surgeons, so they are also quite aware about the complications. So you ask them to stop, they will stop, remove the scope, and you ventilate.
And how much do you all monitor the patient in a dedicated recovery room? For how many hours roughly after a bad foreign body obstruction?
I
Or
always
you all
send
admit
them
the patient?
in the ICU. I always send them to the ICU. Once the patient is awake, maintaining airway, I accompany the patient to the ICU, and there we monitor at least for 12 to 24 hours.
There is a question, madam. Do you use intermittent schooling technique, or you use always a longer acting
See, the
schooling?
thing is that if surgeon says that I'll be like very quick and the duration of
Quick.
procedure is not longer, then I give one dose of scoline with atropine, 20 micrograms per kg atropine. But if he asks me to prolong the duration of relaxation, I don't give scoline, because the second dose of scoline gives severe bradycardia in pediatric patient. So if he says that he needs more relaxation, either you go for atracurium or rocurium, only one dose of scoline, because I have seen bad bradycardias with second dose of scoline in pediatric patients.
Pediatric patients are more prone for this scoline
Yes,
brady
yes,
compared to
yes.
adults.
I don't use IMS.
These rigid bronchoscopes, are there any sizes which we know for the pediatric population which your surgeons have?
It's like, as far as I know, it's like from 2.2, 2.8. The smaller ones, we cannot, they're used in neonatal ones. We cannot pass the telescope from that. I'm not very sure about the sizes, but the smallest one is the 2.2. In a infants, in a 2, 3 year old, we use 4, 4.5 around French.
Okay.
Any more
Okay, Dr.
questions,
Gauri.
Fazil madam? Yeah.
No, nothing from my side. I think we can end this session. And Gauri ma'am, thank you very much for
Thank
giving
you,
your
Fazil.
Thank you,
time.
madam. Thank you,
Also,
Gauri.
we would like to introduce our MMC observer, sir, has joined us. Dr. Piyush Wani, welcome, sir. So we move on to our next speaker. He is Dr. Kedareshwar Pote, and I'll just share his CV slide with all of y'all. Yeah. So, Dr. Kedar, are you there? Have you joined?
Yeah, I joined.
Yeah. Okay. Good evening, and we are very happy to have you on the dais. Dr. Kedareshwar has worked with us in Wokhad Hospital earlier on, few years behind the time as a full-timer cardiac anesthetist, and I am very happy to introduce one of our dear colleagues. So he's done his MBBS and MD from ACPM Medical College, Dhule, and finally he did his DNB anesthesia and his DM cardiac anesthesia from KEM Hospital. He was excellent credentials as a merit holder in MUHS. He finished his FIACTA fellowship and has been a reviewer of Index Journal, which is a journal of pharmacy and bioallied sciences. He is presently the head of cardiac anesthesia at the HVS Hospital, Borivali, and a visiting lecturer at T.Y. Patil, MGM, and Tasgaonkar Medical College. His attachments are to SL Raheja, Wokhad, Fortis, and others. So we are going forward for an enlightening lecture on the cardiac anesthesia side. Over to you, Dr. Kedar.
Thank you, Dr. Fazil, for a kind introduction, and thank you, ISA Borivali, for giving me a chance to present my lecture. I'm not able to share my screen. Can you just stop sharing, Dr. Fazil? Dr. Fazil, can you just stop sharing your screen? Yeah. Okay, thank you. I'm audible? Hello? Am I audible?
Yes, you're very much audible.
Okay. So my topic is anesthesia implications for cardiac cath lab procedures. So as a cardiac anesthetist, earlier we used to just consider cardiac cath labs as standby roles. So we are expanding the role. Just we understand by we used to sit on the chairs and we look to angios and what they are doing. We used to not know anything about that, and we were just concerned about the hemodynamics and everything. From outside, we are now standing at par with the cardiologist, just like in picture Sachin Tendulkar, and if Sachin Tendulkar is our cardiologist, then we are standing just like our Virendra Sehwag, side to side. From this outside to beside, it takes a lot of years of experience to stand along with the cardiologist. So anesthetist in operating room, his role is mainly related to head on the patient. So we have a training as such that whenever we go in OT, we are always standing at the head end of the table, and this is our natural working environment of the comfort zone. So whenever an anesthetist will go in OT, then he will just go and stand in the head end of the table. So sometimes the surgeries are long, so there is hours of boredom, and sometimes in this hours of boredom we will have minutes of thrill and seconds of terror if we are not able to intubate or something like that. So this is our basic infrastructure of the cath lab. So I will go one by one. This is on the left side, you can see the anesthesia machine there. Okay, and right side there is a console. So head end of the table and wait. Can you see my slides? Hello.
Able to see, yes.
Yeah. So this is the head end of the table, and this is leg on table. This is screen. So I would just mark the places where I work. So consider this as a baseball court. Okay. So we'll be starting from first position. I'll go to second, third, and fourth, and then home run. Whenever you complete the 4 steps, you go to home run, means run home. So my first position is on always being an anesthetist. I would like to be on the first side, first 10. So number indicates wherever I'm moving across the cath lab. Okay. So this is my first position. In the first position, we give routine sedation for all elective procedures and primary angioplasties. So earlier at my hospital, we not used to give any sedation, but now all angioplasties we do under sedation. Second is the airway management, where we manage at least oxygenation has to be attached to the patients of primary plasties. There is always a demand supply mismatch, so better to give an oxygenation through a nasal cannula. And first position, again, ultrasound guided access, femoral as well as failed radial. So generally cardiologist takes of radial blind punctures. It is better to have a USG guided access, but generally for radial they do direct procedures, and for femoral we use USG guided procedures. So this is I am showing in the my video. So this is the femoral artery, and then there is a bifurcation. So video will show that how the local is given and where we have to puncture. That is very important. So on the C-arm, you have to see the femoral head, and at the same time, you have to see in the USG where you are puncturing. Your puncturing has not to go below the bifurcation. So again, I'm showing the radial artery cannulation in the pediatric patients. So whenever there are pediatric patients, like for device closures or something like that, so it is better to get a good puncture site. Okay, puncture site we have to learn a USG for an inline and outline approach both. So one technique where we can just put a pediatric transducer in outplane approach. Marking can be done where we find the radial artery. Okay, and then similarly go to the second B image where we can just put one more dot, and similarly third dot, and then we can just connect all the dots, and then we can go in inline approach. So what happens when we directly go in inline approach? We see somewhere, we see the radial artery. Suppose my probe is in this direction, I will not be able to see the whole radial artery, and there are chances that I may go through and through radial artery, or I may not puncture also. So always make a line and then go inline approach, so you can see the whole needle coming and going into the radial artery, and this can avoid such hematomas, large hematomas. So in first position, again, sedation in the cath lab. Sedations are practiced widely, but we have to see what are the cath lab atmosphere around you. And earlier only specific procedures used to be we used to give sedations. Why? Because there was a hesitation from anesthetists, as it was a NORA. It is not an operating room anesthesia where we will use the sedation and we are comfortable, because there is a mobilization problem also in the cath lab. Again, hesitation from cardiologist to give sedation. Why? Because he wanted the patient to remain awake throughout the procedure to check this consciousness. Now the sedation scale, again, American Society of Anesthesiology has classified sedation in 4 categories, like mild, moderate, deep sedation. In mild sedation is just anxiolysis, where respond to verbal commands or reflex are intact. Moderate sedation will give conscious sedation, maybe in the form of dexmedetomidine, where patient respond to stimulation, airways patent, and there is no serious depression. And in deep sedation, there is assistance to maintain the airway, and sometimes we require an inotropic support. In general anesthesia, we do elective intubation with initial CVS sublation. So in cath lab, we generally give a conscious sedation level. Injection dexmed is used. I generally prefer dexmed. As the madam said, dexmed is a classic drug. Sometimes there is bradycardia, but yes, you give with glycopyrrolate, you will see less bradycardia and hypotension with that. And sometimes we have to add benzodiazepine and opioids, like when we are doing the procedures of TAVI, we can give a benzodiazepine along with the dexmedetomidine. So advantages of that, it reduces pain and anxiety of the patient, so their radial punches are easily done. And if patient is anxious and he moves his radial, there are many pricks and radial artery might go into the spasm. So when the patient is comfortable, again, the cardiologist is comfortable and outcome is good. The disadvantage is patient is a very obese patient. Sometimes you might have a noisy airway. we can put a nasal airway in such case. Or sometimes the patient is on the cath lab table and patient is very uncooperative, right? And you give too much sedation, then again we have to maneuver the airway, and if they are putting a stent at that time, if the patient moves, then again the cardiologist get his orientation is gone. Okay, and sometimes if too much this sedation is given such patients, then there can be required an inotropic support for some same patients. So again, coming back to positions, so going to the second position. This is my favorite position in the cath lab. This is second position. Where I take a role as an echocardiographer. Okay, sometimes you have to take a role as an echocardiographer. I just run the video for you. So this is the video of the mitra clip. Okay, TT mitra clip. So the transseptal puncture is taken and the catheter is taken from this side, going to the mitral wall, and the clip is placed. So I will come in detail of the echocardiography in the next slides. Pacemaker and AICD USG guided vein access. So we have seen many times the cardiologists generally take the puncture blind. So what happens? There are many punctures taken, and it is difficult to find veins. So when we are using image guided procedures, then it becomes a very easy. I'm just trying to run the slide. Okay, on this screen you can see me taking subclavian puncture for pacemaker. Okay, so it becomes very easy to take a puncture using USG guided rather than putting a patient at a multiple pricks. Then again, when there is a simple plasty going on, and when I am standing on the position number 2, so the cardiologist is very aware that yes, something is wrong. Means on the position 2, what I told, you can see there is a defibrillator there present. Okay, so normal plasties, and if I'm standing here, then something is wrong, and this cardiology can look at the screen and look for the hemodynamics. So this is a very dangerous position, but yes, very useful position for the cardiologist too. And heading rota console. So nowadays all plasties have many rota guided plasties, OCT guided, and IBUS guided plasties. So the console of rota is always placed here, and he has having a rota controller here. So whenever we should learn rota, OCT, and IBUS, what is there on the screen, and when we learn such things, it becomes very easy to interpret what is going to happen, and what if something has gone wrong, then we can just change the position from the 2 to position 1, and then help the patient as well as the cardiologist. So just like a Harry Potter having a magic wand, we are having a magic T probe. Okay, at position number 2, this T probe is of immense importance, especially in cases of the repairs like mitra clip repair or the tricuspid clip repair. We have seen in Mahabharata, right? Suppose a cardiologist is not able to see what is going on the screen. Okay, when we are doing the mitra clip or tricuspid repair, so a cardiologist is not knowing where exactly he is. So with the help of the T probe, we can help him, just like Sanjay is helping, can help him to guide where he is going with his clips. So this is the recent case of an adult female, 77 years female, operated case of mitral valve, bioprosthetic valve along with the CABG. So she has came with a severe TR. I will just run a video for you. So this is a severe TR in the echo, posted for tricuspid clip repair. So in that we will.
Can you go full screen, Dr. Ketan? You go full screen.
Yeah. Oh, sorry. Okay. Can you see the video now?
The slideshow mode. Screen is visible. Can you go in the slideshow mode? Then it will be better.
Slideshow mode, no?
No.
No?
You aren't in slideshow.
Just a second.
Yeah,
just a
now
second.
it's
Okay. So this is a severe TR. This is a short axis view where we see the aorta. This is right atrium, right ventricle, and we can see the severe TR touching the jet is touching the wall. Okay. So now we have guided the cardiologist to come from the IVC to RA to RV, and thus put a clip So we have put it 2 clips. This is of the, I think 3 days back we have did this case. So I'll go step by step. You can still see the severe TR going there. And this is what rule at position number 2, right? When we put a TE probe, there's also a 3D TE. So we have to learn the 3D TE, as this is the demanding branch, right? Like image proctor, something called anesthetist becoming an imaging proctor is a demanding thing. So what we see in the 3D, so this is our aortic wall. So touching to the aortic wall is always a septal leaflet, and this as we are seeing from posterior side, where T probe is here. So this will be again posterior leaflet, and this is anterior leaflet. So what we have done, we have put a one anteroseptal and posteroseptal mitra clip, tricuspid clip there, and the tricuspid clip is placed, and then you can see the TR jet is now just a mild TR jet. After putting a clip, there is only a mild TR jet. Now we have put the clip here and here. So this is how we can help a cardiologist to do clippings. Now this is again one case of mitral regurgitation where they put the clip. Again, here we act as their imager. Means they are seeing on the screen, they are doing angio and everything they are doing, but we are guiding them. This is our work to guide them where they have taken the transseptal puncture there. Okay, transseptal puncture have where they have to take. It has not to be too anterior, too posterior. Again, we have to see whether you are too superior or too inferior. All the angles, 3D, we have to explain them so that they can go perfectly in the tricuspid clip also. So you can see on the right side of the screen, there is a severe TR jet coming from here. So what we have done, yes. So now this is the 3D view of the same patient. So this my aorta is at 12 o'clock position. Okay. So corresponding to the aortic wall is always a anterior leaflet. This is the posterior leaflet of the mitral wall. So what happens? They come from here through the septum, take a transseptal puncture, and then they go through this into the LA to LV, and then they put a clip. I'll just show in the next slides how the clipping is done. So this is the severe mitral regurgitation. You can see in the 3D. This is the animated view I have shown. Earlier I have shown the 3D view. This is the 3D view, and this is the animated version. And this is how the clip is there. This is the left atrium upper side. This is the left ventricle on the lower side. They put a clip. They take the leaflets and then just pull it. Okay. So we are clipping the A2 B2 segment. So this is like Alfieri stitch, what they do in the intraoperative. This is we are doing it in the cath lab. From the second position, now we are moving to the third position. Third position is again a very important position where but as an anesthesiologist, we don't know about anything about this third position, right? Here a technician stands, and these are the places where now a branch is involving, where anesthetist has to be actively involved, getting what is done there. This is the third position. So this is OCT and IVUS. So how the OCT and IVUS is helping a patient of a stent. Whenever they place a stent, they check it with the help of the OCT or IVUS whether the studs are completely expanded or there is an under expanded stent. Again, handling the pacemaker at the third position during the transcatheter wall implanted TAVIs. So what is our role in the TAVI? Again, suppose there is an inflating wall where we do pre-dilatation, and then we put a wall. While putting the wall, we have to do the rapid pacing. Whenever rapid pacing is done, always be on the position number 3 so that you handle the pacemaker, not due to the technician, because the technician don't know the hemodynamics when he's going to fall and what is going to happen. So you know, whenever they are going to dilate the wall, at that time you need a less annular gradient, right? The BP has to go down, and then they can just dilate the wall. Again, we can be a useful person at position number 3 whenever there is an emergency, whether the cath lab technician also busy in opening some like sheets. So this is the OCT which I am showing you. So in this OCT, we should know this is the 3D OCT, okay, where we can see how the OCT is done. This is our catheter going inside the whole line, and this is a 3D where we can just see. I will just show you what is 3D. Yes, now you can see from inside. This is the guide wire, we can nullify the tissues. We can just see the studs, whether studs are completely expanded or not. Now I will show it. Yes. Now the tissue is gone. This is the studs. Again, tissue is coming. Guide wire is gone. So we can get a clear idea of how the stent is expanded or not, and we can guide him, right? Already the person is always there at OCT and IVUS, but if you learn it, then you will understand. First, you have to understand and make cardiologists confident that you are able to handle the IVUS and OCT. If he is confident that yes, you are able, then there is no need of the OCT technician or IVUS technician, because you have that much of knowledge that you can say whether the stent is under expanded or not. Okay, in the TAVI, this is what I was explaining about the TAVI procedures. The first, they cross the wall, that's shown in the image on the left side on the wall, and then there is a pre-dilatation. I just need to, yes, this is what the crossing the wall is, and this is the second image where they are doing the pre-dilatation. See how the pre-dilatation is done. There is a rapid pacing. You can see the in the second image there is rapid pacing going on, and there is again wall placement. Wall placement again there is a rapid pacing, and this is the final result of the TAVI. So from going third position, now we are going to the fourth position. This is also very important position. I always insist anesthetists to stand on the position 4 instead of position 1. Yes, you go in the cath lab, you check your position number 1, like your machine, scope, blade, everything, but you should stand on the fourth side, because from here you are able to see the screen very clearly. See this, all the hemodynamics you can see. The LED screen is coming in between and you are not able to see the hemodynamics. So it is better to stand on the fourth position, where you will get the less radiation and you are able to see the hemodynamics more clearly. Again, you should also have some knowledge about the hardware support which they are using, what they are using, and we can be man in emergency. If they want a second assistant, we can just wash with them and help them in their procedures. I'll just show you what are the. So these are the mostly used catheters. We should know basic JL, JR, AM2, A2, Tiger. What are they using? If you know these things, then at least if you tell that this is going to work and this is not going to work, then at least confidence comes from the cardiologist. Yes, this person knows, and we can increase our value in a cath lab. So this is what UHG guided now we are seeing. Everyone sees differently. If you show this picture to interventional, you will see artery, vein. If you show it to cardiologist, you will see only artery. But yes, as an anesthesiologist, we are God gifted to see everything. Okay, so we see everything. We see artery, vein, and nerve. So whenever the procedures like a TAVI, they are taking a femoral puncture, just give a femoral block before the procedure. The sheets are very huge size. There's a lot of pain there. Okay, so you can just, we know that cardiologists do put a local anesthesia, but yeah, the block can definitely help the patient with less pain to tolerate the procedure. Now how the puncture is taken, on the left side, A image is there. We should take on the femoral head. Now on the B image, what I'm seeing is the bifurcation. What I told initially, we should just go above the bifurcation till we see the single femoral artery, and then we should take the puncture. Another puncture site where the puncture is taken, you can see the femoral head here, and we should be below the inferior iliac artery. Puncture should always be below the inferior iliac artery. At the end of the procedure, you do, whenever the plasty is done, just tell them to take one shoot. If the creatinine, everything is normal, use minimal dye, take a shoot and look for any leaks at the puncture site. So leak at the puncture site can be avoided if you, as an anesthesiologist, help them for a cardiologist to take an inline puncture of a femoral artery. If we directly take a blind puncture, we are likely to go through and through puncture as there, and then there we can see the big huge hematomas, and then patient complains with the rapid HB loss and something like that. So better to avoid that, you take a UHG guided puncture and help the cardiologist as well as the patient in better recovery. So the thing to be taken into account is this is the micro puncture set, right? Now normally what the cardiologist people at the centers do, they take a puncture right, a wide bore needle. So this is micro catheter and micro puncture needle. Take a micro puncture needle, put a guide wire, and then railroad a micro catheter over it. And then after putting a catheter, you can pass the normal sheath wire through this. So this can avoid unnecessary huge femoral hematomas which we see in general practice. So routine workflow for me as a cardiac anesthetist in the cath lab. First, meet the patient, make them comfortable, explain the procedure, always explain vocally what we are going to do and what they are going to feel, and after how will be the after procedure shifting and everything will be done, like ICU and everything we have to explain. So he becomes more comfortable. Offer sedation, always give sedation. Like I told, nowadays PCI has to be given with sedation. Like any intervention like plastic has to be given sedation. Attach ionotropic support if required. Keep it standby if you're not directly giving it, but keep it standby. Second, access, like scrub and get USG guided access. First, for this thing, you should have a good communication. The cardiologist should have a faith on you that yes, you are capable of doing a good puncture sites. Okay, and then you hand over to the operator. Finally, go to their sites, like manage hemodynamically, and like I told, between the third and fourth place, you have to do the imaging. And sometimes, if the clips and TAVIs are there, then you can stand on the base tube for the TE or the thoracic ecography. In conclusion, like number of procedures now are increasing, and more complex procedures will be coming in the cath lab. As an anesthetist, you should have a good training and good knowledge of the things used in cardiology world and how they are doing it. Anesthesia department as such should incorporate in training plans and plan ahead to cope with the population of patients. And yes, always there should be a communication between the cardiologist and anesthetist to develop a good faith. Thank you. Over to
Thank
you,
you,
Dr.
Kedar.
Fazil.
Thank you, Dr. Kedar. Are your slides over?
Yeah.
Okay. So it was a very lucid presentation, except that the non-cardiac anesthetist, I'm sure, would be struggling to know the 2D echo images and the advanced TE images and the videos that you have very kindly displayed. But,
so what I feel,
yeah.
every time there should be some basic things to be learned from conferences, right? Like basic transthoracic echo, basic TE echo. This is a right. You should understand what they are doing. If you don't understand, if there is a dissection and they will just not tell you what that they have done the dissection, you should understand what is going on wrong and whether there is a pericardial tamponade. So why the blood pressure has fallen, you should be able to catch up.
Someone has unmuted.
हाँ ये चद्दर देखो मुझे दिखाओ मैं बताती हूँ
Okay.
Background noise.
Go ahead.
So there is a big learning curve of transthoracic echo, transesophageal echo, and routine conference has to be attended. Like USG guided puncture, we are already doing as an anesthetist. Blocks, we are already doing it. So this is the developing thing which every anesthetist should know. At least transthoracic echo and somewhat basic views of transesophageal echo should be known to every anesthesiologist.
Right.
So next time we can have a transesophageal echo classes lecture.
Yeah, sure. So I read somewhere that anesthetist is a person who, the regular anesthetist rather, is a person who has a hobby which it can pursue even in the operation theater. And a cardiac anesthetist is a person who can hold no hobby because he is holding the echo probe and he has having a godlike complex, which is not true for you because you're very humble. So having said that, I would like to ask a few questions because I am working every single day. I'm not sure about how many people here are working in the cath lab, but we are getting a lot of cath lab calls. So regarding the anesthesia part, what do you suggest as a definite GA indication for a cardiac procedure? Definitely upfront go for a GA. Is it a TAVI or a septal defect closure where you definitely go for a GA, or you'll go for a monitored anesthesia care in all the cases?
So for definitely GA, if the patient is already, if you see the patient hemodynamics, the patient of PAMI has came and he's having a good cough, like better to go for a GA. In early stage, giving GA is very comfortable. Not for TAVI. TAVI is only done in sedation. I do it in sedation, no TE probe. Okay. For the clips, if any the mitral clip or tricuspid clip is there, then we must give a GA to the patient as we are putting the TE probe, and TE probe will be in the place for the long time.
Yeah, the
And
shared
for
airway
the
of the
device,
TE probe.
yeah,
Yeah.
yeah, and for the ASD device or VSD device closure, better to do it under sedation.
All right. And is there any other specific precaution you would take if a person comes up with a frothing? Suppose I'm getting an acute myocardial infarction patient who is already in left ventricular failure and pulmonary edema has set in. The patient has been occasionally maintained on the BiPAP, and you are worried that patient may have pulmonary hypertension. So what precautions would you take in such kind of a patient, which we frequently encounter?
You see the saturation, if patient is already on a BiPAP and 92 saturation or 93 saturation, better to intubate. See, doing plasty in a moving patient it is very difficult to do plasty. Then the patient will complain of the my bladder is full, or he will move this way, that way. Then it becomes very difficult to get a proper stenting position, right? So better in straight way, go for the GA in that patients. Yeah, if the patient is comfortable, or you can just use dexmedetomidine along with the glycopyrrolate as the madam told, you can avoid the bradycardia part.
Right. So you suggest having a backup airway equipment in all cath labs, definitely.
Yeah.
Because anytime it can be a crammed cath lab space and there's no space to actually go out of the cath lab and get the drugs and the medication and the airway equipment. So all cath labs should have it inbuilt. What about the
because
activated clotting time? Are you all monitoring it frequently?
Yeah,
The ACT.
not like, yeah, they do give, like for a plastic, they give around 100 units per kg they give, and at the end of the procedure they see the ACT, accordingly they try to whether they remove the sheet or not, right? And that all depends whether how the patient condition is. If the patient is unstable and coming from
Right.
PAMI, and we are shifting, we have to shift with sheet, then we are not going to remove the sheet, right? In that case, patient wise it will vary.
A common problem that sometimes I face, at least, that when my patient has come up with some little bit of NORAD going on, and the cardiologist says that it's probably a single vessel, but already it's probably an RCA and little bit of NORAD is going on. And the patient doesn't have an arterial line in C2 because the patient has been wheeled in directly from the ER to the cath lab within the golden period, and there's no art line. And you have an NIBP cuff which may or may not be functioning well because of various reasons. So till the time the arterial line is attached, and even intermittently when they are doing the catheterization, the ballooning, the art line is not showing any value. So is there any way to get our life simpler in that?
There is no way. You just have to, if you are in doubt, you can just tell the cardiologist to rotate the knob and show you the blood pressure.
Okay. Once they put the catheter out, you can get the reading, and then they can proceed
With
again.
catheter also they can show you, no? When the catheter is going in and is in place, they can show you the blood pressure.
So they can show you the blood pressure.
Yeah.
Okay. And for the sudden arrhythmias, what backup do we need to keep ready in the cath lab?
Sudden arrhythmias means so you should know the catheter, where the catheter is going, right? When they are just engage the catheter and there is sudden fall in the blood pressure, that means there can be an ostial lesion, right? So even the cardiologist understand there is an ostial lesion, he will just remove from the ostia. And then there is a left main is there, and then also RCA ostial RCA is there. Then there will be sudden fall in the pressure might be there. So we should know what things are going on. That's what I'm telling you, that we should know the catheter, what they are using, and where the catheter is going, whether it's going to RC or left main. If we don't know that, then how can we judge the patient, right? So we should know about the catheters. Basic things we should know.
Okay. An external defibrillator pads should be kept ready.
Always keep ready. Always.
Yeah.
We never know. That I told you in the
We
position
have
number
the
2, we have a defib paddle on
right.
the left side of the patient, always.
So the NORAD syringe should be loaded and ready and connected, and the IV should be running.
Yes.
And if there is a defibrillator, it should be ready with the jelly and everything applied, I think.
Yes.
I think that calls for any more questions. If anyone, I'm not seeing any in the chat box. Dr. Pravin, would you like to add?
Yeah, madam. Hey, so for us, for non-cardiac anesthetist, we are not very frequently called in the cath lab. And
Okay.
whenever we are called, we are just told, sir, aa jao, standby hai. After 15-20 minutes, the cardiologist will ask for some sedation. Thoda fentanyl de do. After 15-20 minutes, the cardiologist will ask, thoda propofol de do. And then the patient collapses, and then
Tube
you are
dal do.
expecting tube dal do. So for us, it is full zigzag. So better, जैसे आपने you told कि you start sedation initially only. You don't wait for the patient to get irritated and then you sedate, then you over sedate, then you intubate. I think better to sedate them prior only. And I personally don't work much in cath labs. No, I don't see any more questions in the chat box, madam.
Yeah. Okay, with that, I think we can thank Dr. Kedaresh Putte for giving his time, and we really enjoyed the session. And also, I would like to call upon Dr. Piyush Vani, sir, if he wants to speak a few words, sir, we would request you. He is an MMC observer for tonight. Dr. Vani?
I think sir is not there.
Is sir there in the meeting? I'll just see. Wait.
Farzin, I think he has left.
Yeah, sir, he is not there in the meeting. Okay, so can we call upon Dr. Krupa ma'am to end our session with a vote of thanks?
Good evening, everyone. It was an excellent presentation by Dr. Preeti Dikshit, Dr. Vanita, Dr. Gauri Pawar, and Dr. Kedaresh. So we have these topics are very rare because we come once a while, these topics, and we get to know how we can do it properly by this presentations. It also shows we have to be in sync and tempo with your surgeon like ENT and cardiologist. So thank you all speakers, and thank you moderators Dr. Farzin and Dr. Pravin Bhati for excellent moderation. Thank you Jenica and Sams for the platform. Thank you all delegates for patient listening. Thank you ISA from ISA.
Thank you, ma'am.